I'm John Helfrich, currently Chief of Staff at Sinai Hospital of Detroit. I'm with Dr. Ronald Trunsky this afternoon, Vice Chief of Staff, and it's December 9th, 1983. This afternoon we'll be interviewing Dr. Julien Priver. Dr. Priver, for 28 years, was Sinai Hospital's Chief Executive Officer, and we thought it would be appropriate, now that Sinai is some 30 years old, to discuss with Dr. Priver how he came to Detroit, some of his thoughts about the beginnings of the hospital, and where he sees healthcare administration and medical staff administration going into the 90s. Dr. Priver, how did you become interested in medical administration after graduation from medical school?
Well, John, I got out of school in 1940, and I was interested in public health. I had become enamored of the stories written by Paul de Kruif, such as Hunger Fighters and Microbe Hunters and Arrowsmith as a takeoff of that. And I decided that I was going to devote my life to that kind of activity. Along came Pearl Harbor and 4 years in the Army as an infantry physician, which put a kibosh in line of my thinking of going to Hopkins or Columbia and getting an advanced degree in public health. By then I was married and I had a son, David. In restoring myself to civilian life, I had noticed in the Army that most of the hospitals were under the command of medical officers. And in probing in civilian life, I found myself a residency in hospital administration at the Hospital for Joint Disease in New York, under the leadership of Dr. Jack Golub, who has since passed away. Now, to tie that in with Sinai, Dr. Jack Golub was consultant to the community of Detroit, having been engaged by the Jewish Welfare Federation to guide them in the establishment of a hospital which had been under consideration for 30 or 40 years.
And this was about what time? This was in the late 40s? Or?
This was in the late, probably around 49 and maybe 50.
Mm-hmm.
And Dr. Golub, under whose guidance I began my studies in hospital administration, and who had recommended me then for an associateship at the Mount Sinai Hospital in New York, gave my name into the search committee. And for better or for worse, I was selected and interviewed here and came here, and when there was no hospital in existence, but rather a building just about beginning to be constructed.
Were most administrators, medical administrators, at that point in time physicians? Were most of them master's degree type administrators? What was their background generally in the 50s?
The men in the field that I was most related to, and I say that because this was the lineage that I followed, were such names as Dr. Goldwater, Dr. Bluestone, Dr. Turner, Dr. Steinberg, and there were a few my contemporaries in medicine who were going in for this. I think the situation has changed a great deal since, probably because of the more exciting areas elsewhere. To me, I find, although I'm still imbued with a love for public health, that it's never quite as attractive to the community as being a person who can demonstrate cures and healing, which is much more evident, much more quickly.
When you came to Detroit in the early 50s, how much work had been done in preparing the groundwork for a hospital?
I think that there had been talks from the turn of the century about buy a brick to help the sick, various agencies, and there had been even some misapprehensions about the hospital, that if it was to be a Jewish hospital, it would be for all the Jewish doctors in the community. That was, it was one of our major problems, as a matter of fact, because with a 200-bed hospital that was contemplated, there were better than 600 or 800 physicians that were immediately interested, and maybe hundreds of others who could in no way be accommodated. so that those who were interested and got in were pleased to some extent. At least they were here and they were part of it. Those who didn't get in immediately caused some heavy waves.
Who were some of the people, medical and lay people, that were very instrumental in this early development phase?
Well, recognizing that there had been no hospital, my classic recollection is when we got here and my wife said, well, what do you do now? And I said, I don't know. But I packed a little bag and I went to the key people in the medical world in the Detroit area. The medical school, the dean, leaders in the various departments, Harper, Grace, Mount Carmel.
How were you received? Were you received as a competitor, as a colleague? Were they anxious to have you join them in the medical community? Or?
Well, I'll tell you how, as an example of the marvelous reception that we got from our colleagues, absolutely no feeling whatsoever of conflict. I was invited to Harper to the medical staff meeting and met Dr. Barnett and the current administrator, George Cartmill, and we were very friendly. More than that, I think I can demonstrate that we had to pick about 10 leaders to 10 key departments. One of them was pathology. The pathologist was Dr. Kobenek, credit to the institution, who just retired. Dr. Kobenek came to us, and we were about to open the hospital. We found that he didn't have a license in Michigan, and that all the plans would have to be delayed until we came to Dr. Plynn Morse, M-O-R-S-E, who was then the chief pathologist at Harper, and he said, don't worry, I'll make Dr. Kobenek a resident, and I'll be responsible for the laboratory at Sinai Hospital. And so we were able to open on time. I think that, if anything stays clearly in my memory, it's Dr. Plynn Morse and his genuine example of friendly cooperation.
You have mentioned on occasion the fact that there was a public need for this hospital, and there was also a need within the medical profession for graduate education. Could you expand on that some?
Well, those were the days when there was still a shortage of hospital beds, which sooner or later became turned around. But history will tell that story later on. The Jewish community felt keenly that they had been served all these years by hospitals under the auspices of non-Jewish associations. The deaconess group, the Catholic group, and so forth. And they justly decided and determined that there would be a major effort needed by the Jewish community to make a contribution to the total health resources of the city. And this is an important factor because rather than being directed toward the Jewish community per se alone, it was felt that this was a diversity, and like in a small community like Louisville, Kentucky, where there may be just a handful of Jews, there is still a Jewish hospital serving the total community. There also was a remnant of the feeling, which was genuine, that the Jewish physicians were not in a position to obtain advanced education. Particularly in the surgical specialties, where there are limited residencies because of the nature of the training program. As you recognize, only so many people get around the table. Medicine wasn't quite so bad because, we all knew as students how you could line up at 10 or 20 in a row, and each of you listened to a heart murmur. And the dude have no effect on the patient except perhaps to either enrage him or to make him feel that he's getting a lot of attention. So these factors combined, and one of the deterrents was World War II came right in when it was about to get ready. But the Jewish community, under the leadership of the Welfare Federation, men like Isidore Sobolov, who at that time was in charge professionally, and the community backing that he got, plus the city itself, there was a matching of funds at that time, and so the the United Foundation, or its equivalent at that time, raised several $1 million. And a crop of new hospitals arose at that time. And one of them was Beaumont, and another was Oakwood, and these hospitals are of the same vintage, approximate. So that's how we came into being. There were always a few people who were comfortable and who felt that starting a Jewish hospital might just be the wrong thing to do. But evidently, people like Harry Salstein, who were strong protagonists of this movement, succeeded.
You mentioned Sid Kobernick, Harry Salstein. Who were some of the early medical leaders?
Well, I felt a little uncomfortable being the only professional and an MD with a new board, a lay board that was very excellent, very determined. And we got together and I said, get some objective medical people as your counselors and advisors. And that would constitute your first board, medical board, or executive committee. And with the advice obtained through my wanderings and the local physicians who were not, some were a little bit less shy than others, it became evident that the fellow that deserved to be the first chief was Harry Salstein. And so he became the first chief of surgery. And then with the theory that the creation of some departments would be enhanced by giving them independence, we went down the line and were in favor of MD anesthesia, so we created a department of anesthesiology.
Was this the standard of the day in other hospitals?
No, it was not. As a matter of fact, this was still the era of nurse anesthesia, which is okay, but there was the lack of, in a sense, the medical, the MD supervision. Even Harry Salstein was still hanging on to his favorite nurse anesthetists. But we started with an MD anesthesiologist right at the beginning. We did the creation of independent departments in psychiatry, which was customarily under the Department of Medicine. There's certain others that grew with time. Department of Dental and Oral Surgery, it didn't even exist in many hospitals, let alone exist as an independent department. And I think that we can cherish the fact that we did that because of its prominence today. This isn't entirely personal, but nevertheless, you're part of it, so I'm glad to say.
So you feel then that the concept of departmentalization, allowing independent departments to develop on their own and not being sections within other departments such as medicine or surgery was beneficial?
Yes. And we went down the line in medicine, surgery, obstetrics, of course, which were the traditional major departments, even pediatrics, laboratory, x-ray, ear, nose, and throat. At that time was combined. Eye, ear, nose, and throat was one specialty. But I think one of the things that we could mention at this point, which made us a little bit different and maybe a little bit ahead, was the concept of full-time clinical leadership. That was still anathema in this area. The support came from a limited number of your key physicians. Dave Sandweiss's name stands out as a backer. It was a dangerous thing because I sensed that as I wandered to other hospitals. I was even deterred by one of the chiefs of medicine at Harper who said, why do you want to get into trouble? Because the introduction of a full-time clinical leader in any clinical department was not acceptable to the staff. It was looked upon as a competitive move.
A threat to the voluntary staff.
Absolute threat. And believe me, I always felt, and still do, that the hospital is built so that the practicing physician can take care of the community. It was not built to put full-time people in there. But it was demonstrated, to my satisfaction over the years, that the full-time leader was there to serve the physicians in practice, to help them with their problems, and to see to it that their needs vis-a-vis the hospital and their practice were properly worked upon, conveyed to the proper authorities, and in essence carried out. so that the education program was stronger and the teaching activities could be spelled out better.
Has teaching been a part of the institution since day one? Has it been one of the early...
Well, we take great pride in having had a full complement of interns before we had the proper accreditation. And I think it's attributable to the fact that with the help of men like Dave Sandweiss and others, that we were able to obtain the services of a Dr. George Eusterman, who at that time was just being let out to pasture at the out west, and I'm trying to think of the name at the moment, at Mayo's. And he was a man of fine reputation. In fact, we think the answer of his success was that he was such a fine man that he was beyond anybody's ability to attack, and he was hors de combat. He was a fine gentleman, the type of man in whose presence you tend to behave properly. And
his role was really to develop the educational programs?
Yes, he was the first chief of medicine, but also the director of education. And it took one brunch in a downtown hotel with the invitation of the student body of Wayne University to get us a full group. We're proud of them because many of them are still with us, and all but one, I think, are still alive. And some of them have become leaders in their own right, both here and elsewhere.
I'm sure you had a tremendous amount of responsibility in the early days, and you needed some help. Who were the people that were around to help you administratively and in terms of the early board leadership that gave you the type of support that you needed?
Well, from the standpoint of the board, Max Osnes, our first president, had and still does have an intense love for this institution. It was even his father who had made a sizable contribution toward the X-ray department, and Max made himself available to me at all times. He had already served as a board member and was serving, I believe, at Children's Hospital. He was interested in the welfare of children out at Lapeer, and he had one of the better backgrounds in terms of hospital experience of any of the trustees. And his loyalty is something that we were always proud of. From the standpoint of the administration, we had some changes in the early days, but finally Sidney Primer arrived and stayed with me for many, many years, and I couldn't have wanted anybody to be around that I could have depended on more effectively, both from the standpoint of loyalty and ability.
What was Sid Primer's background?
Sid Primer, interestingly enough, had been an RN, and his work led him to the operating room. And I don't know what it is that makes a person stand out as being acceptable to administration, but he stood out. And he was picked up by some leaders in the East, and they made him what he is today. They allowed that to happen, and I think he's grateful, and so am I.
Dr. Priver, you were mentioning some of the key people that helped you in your administrative responsibilities, and surely there must have been a gal Friday that was a right-hand person to you.
Well, the story would not be complete without such reference. As a matter of fact, Lillian Skidmore was with me since 1947 in New York. I knew her since she was a young girl just beginning in the field as a stenographer, typist, secretary. And when we were called upon to come to Detroit in 1951, both she and her husband, Howard, came along, and I can't say too much about what she's done for me. She did all the things that secretaries should be doing and more. Knew my personal habits to the point where if I came in from an hour's drive from Lansing, she knew that she shouldn't let anybody in for at least 5 minutes. And these accommodations were things that I deeply appreciated because they they added to my comfort, and this she did for all these years. She's still with you, as you know.
In fact, I've had the opportunity to work with her in the medical staff office as Dr. Trunsky, and we certainly can appreciate your strong feelings for her abilities. She certainly has been a very important person in Sinai's
She has a compulsive nature which makes her unable to rest until whatever the job she has is done, and done well.
Dr. Priver, if I may, you mentioned the name of Harry August before, and we all know that he is one of the fathers of psychiatry in our community. How did the development of the Department of Psychiatry get started, and how was that looked upon in a general hospital to have an independent department, not under medicine?
Well, Harry August, as we all know, has got a pretty strong personality. He was one of the first 10 chiefs. You couldn't hand wrestle him down very easily, and he wanted this department, and he demonstrated its usefulness by almost immediately getting a group of colleagues to offer services in evening clinics. And it was set in the evening so that partly for their convenience, but also partly for the convenience of the working people who couldn't attend clinics during the day in psychiatry. And so he instituted night clinics right away. Then also became the matter of getting up to the clinical floors. And so there was a consultative service that became available to private patients as well as to the indigent. But behind it all was a desire to have a bed service. I had come from the Mount Sinai in New York, where there was a 28-bed service under a Dr. Mo Kaufman, who was one of the pioneers. They used to put out a newspaper calling the 28 patients the lucky 28. So the concept of psychiatry in a general hospital was just beginning to get in there, instead of sending people out to the state institutions and away out of sight, where they wouldn't bother you and you wouldn't feel bad at looking at them. So along came a depression, and it was, we call it the Eisenhower Depression in the middle 50s, or late 50s, I'm not clear exactly on when. And we were told by the Eisenhower administration that if you've got a plan for something, we'll get some money for Detroit. We had a plan for a psychiatric unit of 40 beds. It was like a box in a shoe store up on the shelf. At the time, we were just beginning to build the Schiffman Wing, which had the capability, and still does have the capability, of going up 6 floors. But we were only putting in 3. So we said, hey, we can put this psychiatric unit on top of the 3, and it wouldn't cost too much. We're already in the process of building. That was acceptable to the government. They said, however, you've only got about 10 days. You've got to fill out all the papers. So fortunately, at that moment, we were able to get hold of a fellow named Joe Haminga, from Lansing, who was in charge of the planning for the state. He literally slept in the boardroom, helping us complete all the documents. And I don't have to tell you what it amounts to. So that was it. First thing we knew, Harry August, Lou Menck, the architect representative, and I were on a plane. We flew to Washington, D.C., and we had interviews with the American Psychiatric Association, where they were then offering free advice to general hospitals, because this was still a new thing. We came back with the concept of all kinds of safeguards as to put in, and many of them were installed, but nevertheless the next thing was a search committee. Search committee went around the country looking for people and came up with, interestingly enough, an interesting trio. Dr. Norman Rosenzweig, who has carried the ball ever since with immense success, and with him came 2 residents, one named Ron Tronsky, and the other Don Silver. And there was a chief, full-time, with 2 house officers. And the units was modified. It became 38 beds. Certain rooms had to be converted to offices, but that's minor, and the rest is history. Does that tell us how we got started?
Yes.
And I think that you could lay it to the door, at the doorstep of Harry August and an energetic group of his colleagues. Too numerous to mention, but men who have made a great contribution to your department.
Who were the first chiefs? You mentioned Dr. Kobernick,
Yep.
Dr. August. Who were some of the others in the department?
In anesthesia, we had a young man named Maury Borin, B-O-R-I-N. Oral surgery, Herb Bloom. In medicine, we said George Eusterman. In surgery, Harry Solstein. In obstetrics, Lionel Braun. He's gone. Pediatrics, Samuel Bernstein. Laboratory, Sidney Kobernick. X-ray, Harry Z. Mellons. And psychiatry, Harry August. And eye, ear, nose, and throat was Jerry Hauser. And thank goodness most of them are still around. And the many changes took place ever since. But that was the beginning of whatever you've got today.
Well, as you moved through the 60s and into the early 70s, what sort of issues did you and the medical staff face that were critical in your mind's eye to the development of the hospital?
That could take another hour, but we'll run through it very quickly, if I may. I'll start it. First of all, the nursing was extremely difficult. There were no extra nurses. The nurses that we got, by and large, were those who had been working elsewhere and in some cases, unfortunately, had been let go. We got a good nucleus and a good start, but it was still a strange thing. Why? We didn't have a school of nursing, and so we weren't generating our own staff. The other hospitals had schools, and it was considered the right thing to do to go back to your own school and do nursing or go away to another community. So that's one of the big things then, was to get hands and feet. Now,
is that the genesis of the Shapiro School then?
the genesis of the Shapiro School comes as an outgrowth of that. Well, why not a school of registered nurses? Because the existing schools at that time had vacancies, and it didn't make sense to build another one. A study was made by the Cunningham Drug Company Foundation under the auspices of some assistant dean of the School of Nursing, Mary Kelly Mullane, which demonstrated that what Detroit needed was not more nursing schools, because you couldn't fill the ones that existed, but to create a new concept, which had just started around the time of the Second War, the practical nurse, who could do much of the work that was currently being done by nurses and could spell them out. That was weak and it was strong. It gave us hands and feet, but it unfortunately kept our medical staff away from the nursing that level, because they just never felt that they could bridge the educational gap effectively. Now, I think that at this point, we then had to reckon with what I mentioned before. 600 doctors, 200 beds. What was chaos? 30 beds in a unit, 20 different doctors walking in and out, nobody knowing each other, each doctor having maybe one and a fraction patients. I remember asking the medical staff at that point at a very big meeting, well attended because they were angry. I said, who can name 5 nurses? Any 5. Not one hand went up. I don't have to spell that out, but it's obvious that with that kind of situation, that the most acute subject then was, we need more beds. And so we said we needed nursing. We got a Shapiro School. We got a Slatkin residence, because we found that nurses who did work didn't want to work in the afternoon. That PM shift was deadly. It meant the nurse had to go to work at 4 o'clock in the afternoon and get off at midnight. Who's going to be waiting for her at midnight if she had any interests? And so we got the Slatkin family to give us a residence with the thought that we would offer free lodgings to any nurse who would be willing to work the afternoon shift. Needless to say, it didn't help much, but that's how that came about. But then came the question of more beds, and the question of the outpatient clinic. We had an outpatient clinic, which I should have mentioned probably because many of our medical staff had served voluntarily at the North End Clinic, but it was at another part of town. It wasn't connected. The Schiffman Clinic building arose from this, which gave us more beds, and it gave us an outpatient department. And then, of course, we still continued to have the problem of nursing, but as we grew, each of the problems became more clearly manifest. The library was inadequate, a small room opposite my office. So we got the Frank Library now, which is one of the finest in the area. If you have education, you need conference rooms. You need an auditorium. The Zuckerman Auditorium came. Each one of these became clearer and clearer, not necessarily as a crisis, but in each area there was a need. We knew in 1953 or 54, when obstetrics opened, that it wasn't pleasing to the staff. A New York group of consultants had provided the equipment. Most of it was sent back because our leaders were trained in Chicago, and there are differences in what kind of forceps they use. So the workflow was not acceptable. The germ of a battle for a new obstetrical unit, I would say, must indeed go back 25 to 30 years.
Opening of the hospital.
Opening of the hospital.
Yes. Was financing a problem? All these programs that you had to develop right now in healthcare, the financing issue is probably the major issue. Was it difficult to get certificate of needs if you wanted to put on a wing or to build an outpatient department?
We grew up in the rough and ready days. There were no certificate of need. Nobody gave a hoot about what was going on elsewhere. You could be sitting next to another hospital, and if you wanted to create a residency training program, even though they had one, you related to Chicago, and if you made if you met the credentials and the requirements, you were approved. There was no planning. All this is within my generation. Maybe some of our key men who are still with us were absolutely resentful. How can they tell us downtown that we can't build more beds if we want more beds? Well, that's history also at this stage. But there wasn't any at the beginning. Abe Shrewy, who was our first chief of our Joint Conference Committee, and I went to the medical school. We went to visit the dean, Gordon Scott, just a marvelous man. He welcomed us and he said, "I expect great things from your hospital. And whatever you do that's good for education, I'm with you." And so that in essence it was a very easy thing to become affiliated with Wayne State University, which in one form or another has existed ever since.
You feel that's been important? Has it been important to the institution?
Oh, I think it has. It's great importance to the institution. I think that, if I may go into the future on this one, I think the continued viability of the residency training programs will probably be attached to the university. I think that sooner or later, if you have a good program or not, if it's not related, it'll probably begin to lose out.
Where did the concept of research in a community hospital, how did that generate, and how did Dr. Piero Folo come? And
well, that goes back to the beginning also. Harry Schulstein, our first chief, made a gift to the hospital almost days after it opened for the purchase of several dogs. We had a tiny little space that was put into the plant for research, but it was negligible. Nevertheless, there were a few animals there. We had a veterinary who served us without recompense, and his name was Henry Raskin. He just passed away. He took care of the dogs. Sidney Kobernick came, and he was imbued with an interest in research, and he took care of rabbits, or was making them sick or making them better, but he was interested in the cholesterol and feedings. The Dave Sandweiss, great interest in academics, always talking in research and research. And we felt that we had to make a decision. Do you add a research entity which will be by itself and will do great things like a research institute often does? Or did we want research in a general hospital to be the kind of thing where you get special people who can help the clinician? The same concept that we had earlier in our discussion about the importance of full-timers. And nothing made me happier than when ultimately Piero came through the traditional search committee routes, and Sam Bernstein was talking to him about a brittle diabetic child, and Piero Foa's interest was in diabetes. And when they were talking to each other, I felt that's what we have research here for. Not to get into the esoterics necessarily. I used to kid Piero, and he almost threw me out once when I said, "Piero, why don't you invent a cure for baldness? That would be, not only would it be good for a lot of us, but it would get us a consistent and hefty sum of money." But we weren't totally against theoretical work, but most of the things that we can record over the years that you know, including the mandibular work and the other things that were done
have clinical application.
But we had a chemist who's passed away too, Abe Goldfarb, and we wanted him to lecture to the residents about biochemistry, to join in the rounds. And only to the extent that they do that do I feel that it's a justified situation in a general hospital.
Do you feel that research plays a role in a general community hospital, or does it belong in a university setting?
Well, perhaps it's something that has to be continually rethought, and to be dogmatic could make it worse. But I do believe that if you get not the isolated research activity, that doesn't, in my opinion, does not belong, but the research that is, again, geared to help the clinician, because that's why you're here. And I can't help repeating it, even though those of us who sit in administrative positions and who talk budgets and who are always closing things rather than opening, and who are always on the negative side, are accused of not being interested in the practicing physician. I can't see how you can get along without him.
Now, if we could just take a moment for you to look back over your career, and using that as your experiences as a guide, can you look a bit into the future? Can you give us a little crystal ball facing? Today we're hearing terms such as PPO, PPA, DRGs. Is this something new? Do you see big changes occurring in healthcare and healthcare administration in the next 10 years?
Well, I think it's we said before there had been no health planning. Now there's an abundance of health planning. Now I think we no longer can go it alone. We do have to know what the others are doing. We have to integrate with them. I regret that the quadrangle at the moment is not functioning, but I would hope that sooner or later there'll be some alternative mechanism for getting together. There are larger and larger associations forming. The Voluntary Hospitals of America, under the leadership of Henry Ford, consists of dozens and dozens of hospitals. The PPO you bring up leads one to believe what I heard recently, that in due course there will be a clinic in some defunct department of every Sears Roebuck store in the United States. They'll close up either the furniture department or something else. There'll be a clinic of physicians. People will belong, and they'll relate to the local hospitals. Now that's far-fetched perhaps, but it seems to go. But I think that we have recognized a complete change, and I hope that the private practice will not disappear totally. I think that it should be available, but I think it'll diminish in scope.
Dr. Priver, being the executive vice president of Sinai and seeing it grow and reaching an age where you yourself step down, what are your future plans? What will you do? What about Julien Priver?
I'm glad you asked, because I guess they say if you don't ask, you don't get the answers. But the fact is that I recognize the passage of time. I recognize interest more in traveling and getting out to see the country and other parts of the world. However, I continue to read the journals. I have a subscription to the New England Journal, which comes in weekly, and I can hardly keep up with it. In fact, I can hardly understand it anymore, but it's there. And when I'm invited to do so, I lecture. My interest happens to be in medical staff organization. I have slides and will travel. I relate somewhat to the University of Detroit on that basis and to San Diego State, and intend to get in touch with the University of California in San Diego when I get out there soon. On the other hand, although I have a title of executive consultant, I tend jokingly to reflect the axiom that retirees are more honored than consulted, so that conceivably some of my talent may be wasted. But I have no grievances or any misgivings.
But you have no intention just to sit down and observe the scenery and put yourself to pasture, because you certainly are dynamic, and I've enjoyed listening to the interview.
Well, I appreciate your comments. I feel well. I have a mother, 98, who's still living. Although until about 93 or 94, she had a complete control of her sensorium. It isn't there anymore. On the other hand, when people point out to me that I have good genes, I tell them that my mother did not run a Jewish hospital for 28 years. So I'm not sure what price I will have to pay for that.
Yeah. Dr. Priver, we would like to thank you very much and wish you many years of good health and continued service to hospital administration and hospitals and medical staffs in general.
Thank you, John. And Ron, I was delighted that you called upon me. I enjoyed it more than you can imagine.
Thank you very much.
Thank you.